So we're going to now go right back to the optic nerve, and we are going to discuss traumatic optic neuropathy, which is actually secondary to both either direct traumas or indirect traumas, and that's something which is fairly vision threatening. This is something which probably requires fairly urgent treatment for us to achieve good visual outcomes, and that's the important thing. And so one has to be fairly alert to the diagnosis and to be able to find a traumatic optic neuropathy. So traumatic optic neuropathies basically are a result of deformation forces on the optic nerve, and these deformation forces basically cause the optic nerve to get dysfunctional, and the amount of dysfunctional nature of the optic nerve could lead to either no PLI altogether, or could lead to different levels of visual acuity. But very often when it does happen, it actually causes a permanent vision loss if it has not been, if there is an intervention which is not done in time. And it's seen in a lot of the injuries, about mid-facial injuries, or in terms of injuries of the forehead, of the optic, or of the orbit. So many times you'll see this actually fairly frequently in these injuries. And the type of traumatic optic neuropathy could actually be direct or indirect. And in direct injuries, we refer to injuries where the nerve has actually been avulsed, or it has been cut, or it has been lacerated, or it has been, so these are injuries which are directly affecting the nerve, as against indirect injuries, which are actually because of transmission of a force, usually because of, let's say, a trauma to the suprabrow region of the orbit, or either from the orbital wall getting fractured, some transmission of force, or from a rupture of the pile or the smaller vessels causing a contusion and a hematoma around the optic nerve. So all these are the indirect form of injuries, and there are the direct form of injuries. So it's important to recognize, and sometimes direct injuries could be in the form of iatrogenic injuries. So during neurosurgery, they often may end up touching the nerve. So that becomes a major problem. And when it comes down to looking at the nerves, what's important that you need to look at in the history is to find out cases where the optic nerves do get involved. So look for head injuries, look for suprabrow injuries, injuries around the orbit, and in these cases one has to have a high suspicion for the diagnosis. And the diagnosis is essentially clinical, and in terms of it's basically in terms of looking at the visual acuity, looking for pupillary responses, looking for adnexal injuries around the eye, and it is looking for the presence of later on imaging. But the important thing is that the diagnosis is a clinical diagnosis, and everybody needs to be able to do it. It's not difficult to do, and in fact it is sometimes on the verge, on the side of treating rather than not treating. And the pathophysiology and if we understand the pathophysiology of these, the optic nerve is actually going through the optic canal, and that's a fairly tight area. So any injury that is happening even anteriorly, and that's where the dura is stuck to the optic canal periosteum, so it gets directly transmitted through and through. And therefore, even if nothing really is actually visible at all to you, in just the pupillary responses alone may give away. But we'll also come to some cases where we see sometimes the pupillary responses are not a giveaway, and you may actually end up missing it. And that's where you need to be more careful. Always look for other associated ocular findings. Look for what's happening to the ocular adnexa. Look for what's happening at the back, in the retina and the disc. So involvement of the other portions of the eye. So it's always, that's why the concept of this instruction course was a comprehensive outlook on trauma. One has to comprehensively look at it, and only when you do a proper and a good examination, right from the pupils to a good ophthalmoscopy, to a good clinical examination, the ocular adnexa, one is able to make a complete image of what's happening in that particular patient. And the investigations that we generally require would either be in the form of imaging, where you're doing a CT scan and MRI. And CT scan is to look for the bony changes, and MRI can sometimes help you look for any hematoma there or any avulsion of the optic nerve. Perimetry and VEP is something that we should always do, and always do of what appears to be the normal eye also, because sometimes the involvement can actually be in both eyes. And VEP can give us a very good idea if the optic nerve is functioning properly or it's not. And the treatment for these could be medical. In a large number of the cases where we are giving, this is in the form of giving IV steroids, pulse steroids. You want to give high dose IV steroids in the beginning, and the earlier the better. In fact, it is best to be done within 12 hours, and if you do it within 6 hours, that's even better. It's just like stroke, that there is a golden period to do it, and one should do it the earlier the better. The second option is surgery, and surgery could be in the form of either decompression, or there is a hematoma and then you want to decompress the hematoma, or in the presence of bony spicules. So these are the indications where you want to do a surgery, or if it's not improving, with giving the medical management. But one has to take a decision quickly, because you don't want to wait too long. So I'm going to quickly discuss a few cases of traumatic optic neuropathy and understand how it gets useful. So this is a male patient who's had an injury, who's come with multiple facial injuries, head injuries, and you can see him here. And this is in case of a direct trauma here. You can see that there's a near the optic nerve head, there is a blood there, and it appears like the optic nerve may have been avulsed out. We're not sure because of that. But when you do an imaging, you can see that there is a bony spicule here in the optic canal, which is actually pressing onto the optic nerve and impinging onto the optic nerve. So this is what would be the management of this kind of a patient. So this kind of a patient, what you could do is, the idea is that you need to do surgery, but in the meanwhile you give a steroid so that if there's any hematoma, it does start to settle. And we've done a study at AIIMS, when I was at AIIMS there, that we found if you were comparing giving steroids to patients with spicules versus doing neurosurgery, the outcomes were actually similar, and they were actually poor for both. So, but still, this is an indication where you can go in and decompress the optic nerve and do it early so that there is some chance. Here, of course, the patient unfortunately did not gain vision, and there was a lot of trauma. And these are the kind of patients where the prognosis, is bad. But always do an imaging, always do fields of the other eye, always rule out that the other eye is not involved. Sometimes in just trying to be looking at this eye, one forgets the other eye. And that's a very, very important thing that one needs to look at. This is another case. Of a young girl who's come with an RAPD in the right eye. She's basically fallen down from the staircase, presents, there is a poor vision, the medical officer there looks at it in the casualty, and you come and you see this, an RAPD in the right eye. So the moment you do that, you need to, and you look at the fundus appears essentially absolutely normal. But that is an indication that there's something wrong there. And here, this is again, she's come in early, you want to give steroids right away. And the management would be in the form of methylprednisolone, 1 or 1.5 gram pulse, a high pulse. But you have to be careful when you're giving steroids that there is no other neurological problem, because you don't want to make things worse. So it's better to deal it with the neurology. But if you feel the patient is otherwise oriented, conscious, please go ahead and give this pulse steroid. Here we were able to give the pulse steroid. Later on there was some pallor which developed in this disc, and you did a field and you saw that the other eye is normal and this eye was showing a field effect. But the vision did improve to 6/9, and otherwise the patient could have been left with the 3/60 or worse vision if you had done nothing at that point in time. So one has to do it, and I think more and more the thought process is to do it early and to do it rather than not do it even when you're in doubt. Give the steroids. Here, this is another patient who's presented a little later to the casualty with a poor vision in the right eye. There is a RAPD in the right eye. Now, this is what happens. Here, the vision in the right eye was fairly poor, right, from the beginning when you look at it. And when we did give steroids, there was not much of a good outcome, and there was a pallor, and the vision didn't improve. So if you're doing it late, very often you'll not get a good result. But in my experience, I have actually, even up to a week or so, I have seen that giving steroids has helped, and this is more so where there is basically an edema around the optic disc, around the optic nerve in the optic canal, and as that settles, some amount of vision may recover. But the idea, again, the thought process is to do it and give steroids early rather than late. This is a young girl who had come with an exotropia in the left eye and had a trauma in the early childhood. She had fallen from a tractor, and there was no RAPD at that point in time. But later on, when we realized that both the optic nerves have actually gone into a pallor, and there is a poor vision in both the optic nerves, and when you look at the field effect, you see that both of them are having a depressed field. So this is a case where sometimes the injury could actually be bilateral, and therefore you may not get an RAPD, and you may think that it's all is normal. But in cases where there is a severe injury, you must always do an imaging, and later on an imaging at that point in time was not done, and the doctors had dismissed that everything looks to be normal. But later on she developed this, and now of course it's not possible for us to reverse it. So if again there's a severer injury and you think that there is a possibility of a traumatic optic neuropathy, I think one should think in terms of treatment rather than wait, because if you wait too long and you develop something like this, then there's nothing really that you can do about it. And there are cases, and we've published another case where there's been an injury to the right side of the head and there has been vision loss in the left side, and that's because of an injury there's a fracture in the base of the skull which is going across and crossing the other optic canal. So always examine both the eyes, rely on your clinical findings, but don't rely on them alone. So have a sense of a clinical sense to understand that this kind of a patient could have a traumatic neuropathy, and go ahead in terms of treating rather than not treating them in the first go. At least one dose of steroid, you go ahead and do it. You've done a good job. So I think that's the important thing about traumatic neuropathies. Better rather prevent. There's no other way of treating them. Thank you.